First of all, I'd like to thank the invitation from the scientific committee of this of the meeting, and also specifically Dr. Kieran, who is also like always kind enough to invite me to give talks on this prestigious meeting that happens every year. So I'm going to talk today about soft tissue and some pin care after external fixators are put in the patients. I have nothing to disclose, and specifically related to this talk. So the pin tract infection is one of the most common complications that we have in patients with these frames. It affects up to 100% of the patients. That depends on how long the patient is going to have their frames on, and loosening of the pin is almost like a certainty. Not exactly just a complication. And we got to remember that even though people believe that the cycle is that you get infected and then after the infection you're going to have the loosening, actually what happened is the other way around. Usually the pins gets loose first and then they get infected. So that's something that we have to pay attention on to try to prevent problems and try to avoid treating them after they're happening. So this process can occur in different phases of the treatment. If we remember that before we start treating these patients, we're very likely going to be able to avoid these complications. So, as I said, it's almost an accepted certainty, but the majority of them resolve with pin care, local care. We don't need to bring the patients back to the surgery center. Vast majority of them. A bad infection on the pin tracts can put in danger the whole treatment. You might have to take down the whole pins, one, two, maybe three of them, because of the infection. But we can prevent this from happening, like I mentioned a few times already. So, in a proper planning, not only on the pin, but the whole treatment, will very likely avoid problems during the treatment and also in the future. So, how can we avoid problems on the pins? So, first of all, you got to plan accordingly the treatment that we are gonna offer to the patients. So we do know that the more stable the constructions are, the more stable the pins are going to be, and with that, the chances of having loosening of the pins, they lower tremendously. And we do know that circular frames are way more stable than biplanar frames, that are way more stable than monoplanar frames. So if we're talking about a monopillar frame, very likely going to have infections if you keep that thing in for more than a month or a month and a half. So monopolar frames very rarely would be eligible for definitive treatment in patients needing a frame. So those are usually temporary, because if they're in the patient for more than a month to a month and a half, very likely some of the pins are gonna loosen and get infection right after that. Like I said, the more stable the construction is, the better it's going to be. And also, there's a few small details. So we gotta try to avoid putting two pins too close one another, because if they're too close, they're gonna work as only one point of fixation. So they're not adding stability to the construction. They cannot be they cannot be too close for the ankle joint, and they cannot be close to the bone gap or the bone fracture, because they might crack, and the crack might extend to the ankle to the joint close to the pin, or to the fracture line close to the pin. They also should not be too far away, too apart one another, because you need some connection between them also to have stability. If you're planning to put two pins too far away one another, you definitely should plan to put something between them, one or two other pins, to add stability to your construction. So these are very important things. Remember also the skin. So try to avoid putting pins on spots where there's too much of skin movement, and also muscles or tendons are gliding up and down too much, because you can cause also and have problems on the muscles and the tendons if you put the pins where they're supposed to be gliding up and down. Remember, not every patient is eligible to a frame. So patients like this one here, that is a Brazilian patient that I had, I didn't know about this, but I saw on his like social media and stuff, he was doing this type of stuff. So this type of patient, I am sure that he does not have great care of his frame. So not every patient is eligible to a frame. If you have access to, if you can get the the coated pins with cobalt, they are usually 90 times stronger to and connected to the bone. So you need 90 times higher extraction force to move those guys. So if you have access to it, it's a great advantage. They're more expensive, but they're way better, and they're going to provide way more stability. Remember also, before you take the patient to the surgery center, checking your hardware, your instruments, how sharp the drills are, because thermal injury is a big problem here, and we have to do everything you can to avoid it. So if you have sharp drill bits, the chances of thermal injury on the bones are way lower. Check the size of the rings before you're going to start your construction. They have to be like generously larger than the leg. After the surgery, we always have a moderate swelling on the legs or on the limbs where the frames are inserted, and if you have some swelling and it touches the rings, you're gonna have skin complications at that spot too. So try to remember that we need like a good amount of room between the leg and the rings before the surgery is started. I don't really care about how small the incisions are going to be. And I tell my patients before that these are not just small punch holes in the skin, are small incisions. And that is very important, because if you give yourself like a 1 centimeter incision on the skin to work on, you're not going to have thermal injury on the skin or on the muscle too. And if you have to do one stitch after the pin is done, that's not a big deal. But you'd rather have a longer skin incision around the pins than having thermal injury with necrosis of the skin after 2-3 weeks of the frame insertion, that those would cause more problems to you in the future than just a slightly longer incision around the pins. So this is one of the most important slides of the talk, I believe. I am not a great believer in a self-drilling pins. I know they exist. I know the reps, they tell us that these are self-drilling. This is amazing. They show to us the tip of the pin with some slots in it, telling me that, listen, this is a cutting pin, so you don't have to pre-drill and stuff. But I always pre-drill my pins with a sharp drill bit. I try to put some cold saline solution around the drill bit, also to cool down not only the skin but also the bone. I always use the soft tissue protector, the sleeve. So you find the spot where you want to do the incision, and then with a small snap or a snit, I open the tract with this through the soft tissue, and then with that I put I put the drill bit in through that small incision. It touches the bone. Then I slide the soft tissue protector all the way down, touching the bone. And then before I start, I already put some cold saline solution in the soft tissue protector. And then I put it in. I drill the tunnel through the bone while I'm doing this. While I'm irrigating with more saline solution. If you don't have speed control on the trigger of your drill, of your machine, do like pulsatile drilling. So you like activate and deactivate. So this is gonna stop every 2 seconds the drill, and it's gonna cool down the tunnel that you're doing. And that is also going to prevent thermal injuries in the bone and also on the soft tissue. Still, like after the surgery is done, I usually coat all the pins that I did with a sponge gauze, and then you can use any solution around it. I usually use like betadine around the pins. You can do that every single pin that you put in the construction, and then at the end of the procedure, you can take them all down and do a new one. But it's important for you after the surgery is done, protect all the pin tracks, no matter what type of pin it is. If it's a K-wire, it's an olive wire, or if it's a Schanz pin with a sponge gauze and betadine. You can also use alcoholic solution. You can use saline solution with soap. So I always try to do something like this to keep it protected. And then after everything is done, I just put a wrap around it just to protect from dust, from dirt, from the wherever the patient is, to keep all the tracks, the pin tracks and the frame itself clean and away from dirt. So once this is done, I usually see the patients after a week of surgery, and that's when my first dressings are done. So remember, always, this sounds silly what I'm going to say here, but frequently the first person to tackle this is not the surgeon. The first person very frequently is, for example, a nurse or a PA or an assistant nurse or a medical assistant. You got to tell them, first of all, wash your hands. So wash your hands. And then after that, you can take down all the sponge gauzes that I put around the pins, and then I clean them again with betadine solution, Clorox, alcoholic solution. Sometimes just water with a neutral soap is also very good. They're all very similar. Apparently Clorox can be a little bit more allergenic, but great to keep everything clean. If there's any concerns for infection, you should then bring the patient closer to you. I usually do these things like once a week. If I'm concerned about one or two pins, I bring the patients twice or three times a week. If there's only redness, right? But if there is some small infection, I tend to bring the patients closer to me, and then I try to see them either every day or every other day. And then I also ask them to do their dressings at home, teaching them how to do it. Use like cotton swabs to clean well, and you have to really put some pressure in it to take off any debris that you might have from a possible infection. Well, I lived in Brazil for many years, and patients, they ask me all the time about getting the water, because I mean the summer that we have there is way longer than for example here in Boston, right? But I try to I just tell my patients that they should never swim, never swim, specifically in open water, because sometimes they go like to ponds or to lakes that are not very clean. The water is not very clean, and that can really become a huge disaster. If you do have infection, that's usually a consequence of loosening of the pins. It usually starts with the cellulitis around the pin tract, and then gets worse and goes deeper. You gotta really focus on the local care once the cellulitis starts. Like I said, a local daily debridement it's supposed to be done. You can start with only local antibiotics with some around the pins, and then if it's not getting better, it's not improving at all, then you gotta go to oral antibiotics, and that can vary what type of the antibiotic that you're going to use. That varies according to the flora that you have where you work at your hospital. And if you have pus coming out of the pin, you really have to admit that patient, start IV antibiotics, and start planning to do something more aggressive in order to save the frame that installed on the patient. There is this very nice classification of pin tract infections that goes from grade 0 to grade 5. This is basically starts with just a cellulitis around the pin, goes to more redness and a small amount of pus, but still superficial, and then the pins gets loose and with a lot of pus coming out of it, and then you can even see on the X-rays a huge loosening around the pin with moderate to high amount of pus coming out, and patients sometimes with clinical signs of infection like fever, chills and stuff. And then that's if it gets to that point, you really lost the time to do something else for these patients. So removing the pin. So if it's completely loose and woozing a lot, they should be removed. Signs of vaginal infection, just as I just mentioned before. Also, there are signs that you have to take them down. Sometimes these patients, they can fall, like the guy from the bike that I showed you a few slides ago. They have any trauma and the pins get bent. It means for sure that the stability of the construction is affected and should be revised. So every time that you remove a pin, you got to check the stability of the construction again. Very, very likely the stability of the construction will be impacted because, as I mentioned before, the loosening of the pin is frequently caused by lack of stability, and that loosening will lead to the infection. Every time you're removing a pin, you gotta plan what you're going to do, and that can be either just put another pin close to where the initial pin was, never ever on the same pin track. You gotta go to a different place. And you also have to plan if you have to put another ring with 2 or 3 more pins, change the position of the ring that you had before too, or even plan removing the whole construction and try a different treatment. So in summary, pin infection is usually a consequence of losing and not a cause of the problem. A very frequent complication, almost a certainty. So you got to be ready for it and try to plan accordingly before the surgery is done, so you don't have this type of complication, or you can delay the process as much as you can. Prevention, like I said, is very helpful. You gotta be careful when introducing the pins. So the pin care in the surgery center is maybe even more important than the pin care after. So keeping everything cool with a good with a roomy incision in the skin before you start drilling is very important and very helpful. Keep them clean and close eyes. If any signs of superficial infection they develop, and if you need to remove, understand why the pins got loose and fix the cause. Don't simply insert a new pin. So this is what I had to share to you. Again, thank you so much for the invitation, and have a wonderful meeting. Well, first of all, I'd like to thank the invitation from the scientific committee of the meeting, and also especially Dr. Kieran, who is also like always kind enough to invite me to give talks on this prestigious meeting that happens every year. So I'm going to talk today about soft tissue and some pin care after external fixators are put in the patients. I have nothing to disclose, and specifically related to this talk. So the pin tract infection is one of the most common complications that we have in patients with these frames. It affects up to 100% of the patients. That depends on how long the patient is going to have their frames on. And loosening of the pin is almost like a certainty. Not exactly just a complication. And we got to remember that even though people believe that the cycle is that you get infected and then after the infection you're going to have the loosening, actually what happened is the other way around. Usually the pins gets loose first and then they get infected. So that's something that we have to pay attention on to try to prevent problems and try to avoid treating them after they're happening. So this process can occur in different phases of the treatment. If we remember that before we start treating these patients, we're very likely going to be able to avoid these complications.